Welcome to this explainer on RCOG Guideline number 66. If you're an MRCOG candidate preparing for your exams or a clinician looking to master high-risk obstetrics, you are in exactly the right place. Today, we're going to build a mental filing cabinet for you. We're going to walk through the exact clinical journey of a pregnant patient with beta thalassemia, breaking down a very dense, critical guideline into a clear and highly logical roadmap. Let's dive in.
Here's how we're going to tackle this. We'll follow a strictly chronological patient roadmap, starting with an overview, then preconception care, antenatal care and monitoring, and finally, intrapartum and postpartum care.
Kicking things off with Section 1, an overview of beta thalassemia, specifically looking at pathophysiology and demographics. Now here's a highly testable demographic hook for you. When you hear thalassemia, you probably automatically think Mediterranean, right? I mean, the name itself literally means sea in the blood. But here's the reality today. A massive 79% of UK thalassemia births actually occur in Asian communities, specifically families of Indian, Pakistani, and Bangladeshi descent. Only 7% occur in the Cypriot population today, and that's largely because that group has strongly embraced prenatal diagnosis. The big takeaway here? You must be incredibly vigilant with carrier screening across all diverse populations, not just those from the Mediterranean. Okay, for clinical classification, you absolutely need to nail down this strict numerical cutoff. More than 7 transfusions a year defines thalassemia major. 7 or fewer, or being completely non-transfused, defines thalassemia intermedia. So why does this specific number matter so much for your exams? Because this distinction fundamentally dictates how you manage the patient's iron burden. You see, thalassemia major patients have profound extravascular hemolysis and ineffective erythropoiesis. This makes them heavily reliant on transfusions, which inevitably leads to severe iron overload.
Moving right along to Section 2, Preconception Care and Optimization, focusing on strict targets and medication swaps.
So right off the bat, in preconception care, we have a major medication swap to deal with. The absolute cornerstone of surviving thalassemia is iron chelation. But the problem is, many common chelators are just not safe for a developing fetus. You have to instruct your patients to stop taking difracerox and diferiprone a full 3 months prior to conception because of potential teratogenicity. Instead, you'll pivot them to the safer alternative, which is dysferrioxamine. It's great because it has a short half-life, it's safe for infusion during ovulation induction, and, crucially, you can use it later in pregnancy after 20 weeks.
I highly recommend you memorize these specific targets for your OSCEs and written papers. Iron overload silently destroys the endocrine system, the heart, and the liver. Starting with the pancreas, we need to screen for diabetes, but hemoglobin A1C is completely unreliable here. Why? Because regular blood transfusions dilute it. So we have to rely on fructosamine instead, aiming for under 300 nanomoles per liter. Next up is the heart. We need aggressive chelation to achieve a cardiac T2 star of over 20 milliseconds on an MRI, which tells us there's minimal iron in the heart. Finally, we're aiming for a liver iron concentration of less than 7 milligrams per gram of dry weight. Hitting these targets preconception is absolutely critical because chelation is largely paused during the first trimester.
Let's shift gears from iron and talk about the spleen. Historically, a lot of these patients underwent splenectomies to reduce their need for transfusions. Because of that, they are now highly susceptible to infection from encapsulated bacteria. So, these women must be prescribed daily penicillin prophylaxis, or if they're allergic, use erythromycin. On top of that, you have to ensure a really strict updated vaccination regimen. That includes the pneumococcal vaccine every 5 years, along with the Hib and meningococcal C vaccines.
And please, whatever you do, don't forget the folate. Because of their high degree of ineffective erythropoiesis, these women have a massive cellular demand for folate. Your standard over-the-counter 400 micrograms just will not cut it here. They require a high-dose 5 milligram prescription. Ideally, this should be started 3 months before conception to effectively prevent neural tube defects.
All right, Section 3, Antenatal Care and Monitoring, looking at scans, transfusions, and thromboprophylaxis.
Once your patient is actually pregnant, they are going to need a seriously intensified ultrasound pathway. Notice that really early scan at 7 to 9 weeks? That is vital. A lot of these women require ovulation induction to conceive due to iron-induced hypogonadism, which of course increases the chance of multiple pregnancies. Then, jumping to 24 weeks onwards, they need serial fetal biometry every 4 weeks. Why so often? Well, chronic maternal anemia severely limits placental nutrient transfer, which puts the fetus at a huge risk for growth restriction. You literally have to watch fetal growth like a hawk. When it comes to blood management,
The main goal is keeping optimal oxygen carrying capacity for the fetus. So, throughout the entire pregnancy, the absolute clinical threshold for thalassemia major patients and for intermedia patients who start requiring top-ups because of worsening anemia or growth restriction is maintaining a strict pre-transfusion hemoglobin level of 100 grams per liter.
Now, pay close attention here, because VTE risk stratification is a classic MRCOG trap. Thalassemia inherently causes a prothrombotic state due to abnormal red cell fragments just circulating in the blood. If a patient has had a splenectomy, or if they have a platelet count over 600, they need low-dose aspirin. Simple enough. However, if they have had a splenectomy and their platelet count is over 600, that combined risk is severe enough to mandate both aspirin and prophylactic low molecular weight heparin. Don't mix those up.
Circling back to that iron overload issue we discussed earlier. If your patient has severe myocardial iron loading, specifically a T2 star of less than 10 milliseconds on their cardiac MRI, they are at an incredibly high risk of cardiac decompensation and outright heart failure as their maternal blood volume naturally expands. This acute risk means you have to restart low-dose subcutaneous desferrioxamine between 20 and 24 weeks, and you do this under strict joint cardiology and hematology guidance.
Finally, Section 4, Intrapartum and Postpartum Care, covering our delivery protocols and follow-up.
When you get to the delivery suite, there is a high-yield 4-step sequence you need to lock into your brain. Step 1, always secure cross-matched blood if antibodies are present. This actually happens in about 16.5% of patients because they've had so many repeated transfusions over their lives. Step 2, use continuous electronic fetal monitoring because these babies have a much higher risk of fetal hypoxia. Step 3 is pretty fascinating. You must give 2 grams of IV desferrioxamine over 24 hours during labor for thalassemia major. Why? Because the immense physical stress of labor causes non-transferrin-bound iron to release free radicals, which risks cardiac dysrhythmias. The desferrioxamine neutralizes that threat. And finally, Step 4, actively manage the third stage to minimize any further blood loss in a patient who is already anemic.
Once you're on the postnatal ward, keep these best practices in mind. First, maintain rigorous VTE prophylaxis with LMWH. That's 7 days for a vaginal delivery and a full 6 weeks if they had a cesarean section. Second, remember that breastfeeding is entirely safe and should absolutely be encouraged. Even though the mother needs to immediately restart her desferrioxamine chelation to manage her iron levels, the drug is not orally absorbed by the newborn from the breast milk, so it poses no harm to the baby whatsoever. We've covered a ton of ground today, right? From pre-pregnancy fructosamine targets all the way to intrapartum IV chelation. But as you prepare for your MRCOG exams and, honestly, more importantly, for your real-world clinical practice, I want to leave you with this thought. How are you going to proactively coordinate this incredibly complex multidisciplinary team at your local trust? How will you ensure that the hematologist, the cardiologist, the diabetologist, and the obstetrician aesthesist are all communicating seamlessly so that iron overload never compromises your patient's journey to a safe and healthy delivery? Think about that as you review your notes. Thanks for joining this explainer, and keep studying smart.